Case conceptualization of a Latina first responder navigating ambiguous loss and spiritual disconnection by Christiana Coleman, Kairos University. Trauma, Grief and Loss Specialization, Spring 2025. Introduction. Broad summary of the case of Maria. A routine screening process at her organization led Maria to undergo a course of therapy due to periodic bouts of depression caused by survivors' guilt and religious doubts. Maria presents with prolonged grief disorder, PGD, also known as complicated grief, characterized by intense and persistent grief that significantly interferes with Maria's daily life due to the death of her father of a liver infection and the mysterious loss of her mother during the illegal family emigration. The case under consideration is consistent with the core stressors inherent to human development. The case here displays the intersection of bereavement culture with childhood adversity and occupational stress. Maria experienced an inner conflict with faith after she abandoned the Roman Catholic religion. This conceptual exploration will focus on how spiritual factors, in addition to cultural themes, influence Maria's current grief pattern and her mental health condition. Background information on the client. Maria, a 37-year-old Mexican-American immigrant, came with her parents to Texas at the age of 5. Maria is a high school graduate. She joined the fire department after high school. Maria has been a paramedic and firefighter for more than 14 years. She is not married and has no children. Maria culturally identifies as a Latina. Maria lost her mom at age 5 and lost her dad at age 17, just before her high school graduation. Maria is a Catholic before the demise of her father. Maria is a first responder. Presenting concerns. Why the client is seeking counseling. 1. Maria is seeking counseling for 1. Ambiguous loss and spiritual disconnection. 2. Prolonged grief disorder, also known as complicated grief. 3. Occupational stress. A routine screening process at her organization led Maria to undergo a course of therapy due to periodic bouts of depression caused by survivors' guilt and religious doubts. What Maria hoped to gain from counseling. 1. Maria is seeking meaning. 2. She seeks to overcome feeling of guilt due to loss of her traditional religious involvement. 3. Maria seeks to experience sustained healing, deepened self-compassion, and renewed purpose as both a professional and a grieving daughter reclaiming her story. Assessment of concerns. To determine Maria's psychological profile and direct her care, both formal tests and informal assessments were conducted at the beginning of treatment. Formal assessments used: PTSD checklist for DSM-5, PCL-5, prolonged grief disorder-13, PG-13, moral injury symptom scale, military version, MISS-M, Beck depression inventory-2, BDI-2, Informal clinical tools, clinical interview and timeline exploration, cultural formulation interview, CFI, from DSM-5, and psychosocial assessment, interpretation of results from the assessments. Multiple clinical conditions that included PTSD were detected during assessment tests and seemed to develop through occupational trauma and her past experiences of childhood loss. Maria's cultural and religious values significantly influenced both her symptom presentation and her response to assessment tools. She endorsed symptoms of guilt and emotional detachment on the PCL-5 and MISS-M. She contextualized this through the lens of Catholic moral frameworks, believing she had failed as a daughter and protector. The convergence of formal assessment, narrative approaches, and culture spirit formulations provide a holistic view of Maria's psychological and emotional life. The findings guide the therapeutic process. Pertinent legal or ethical concerns. In the treatment and evaluation of Maria, there were a lot of legal and ethical issues that arose. 1. Screening for risk. A professional screening for suicide risk was conducted using the Columbia Suicide Severity Rating Scale, C-SSRS, which revealed a lot about significant risk that required being watched closely. Informed consent. Informed consent was clearly described at the beginning of the first sections. They addressed the boundaries of privacy. Maria was concerned about how therapy documentation might impact her career. Boundary management has required careful attention. In order to maintain professional boundaries while being warm, the therapist balanced empathy with clear boundaries, and emotions were contained within the boundaries of the session. Cultural humility is crucial too. Maria hesitated at first to disclose spiritual pain for fear of being judged by a secularly oriented therapist. Systemic problems such as structural racism and institutional neglect of Latina first responders are the root causes of Maria's pain. Applicable spiritual interventions. Psychospiritual interventions that incorporate both psychological and spiritual aspects in treatment were used. These include mindfulness-based therapy. Mindfulness-based interventions are therapeutic approaches that use mindfulness, a state of hyper-awareness of one's intentional and external experiences, whether pleasant or unpleasant, in the present moment from a place of curiosity, acceptance, not judgment, and self-empathy. Spiritual meditation, guided imagery, spiritual counseling, and yoga. Collaborative case with spiritual leaders was considered, but Maria declined direct pastoral involvement, though she agreed to explore resources from Latina Catholic theologians, such as prayers by Sir Joanna and contemporary reflections by Ada Maria, which centers around Latina women's lived experience in spiritual healing. Psychospiritual interventions aim to address the mental, emotional, and spiritual facets of my client's well-being. Treatment goals. Counseling theory utilized. The primary counseling approach selected for Maria's treatment was trauma-focused cognitive behavioral therapy, supported by elements of narrative therapy and culturally adapted psychospiritual interventions. Psychoeducation about trauma responses was introduced first as didactic sections. Cognitive restructuring was used. Such reframing enabled Maria to begin to process through symptoms with compassion rather than judgment. Grounding techniques were another central feature. During a flashback trigger related to her mother's disappearance, a therapist coached Maria through diaphragmatic breathing and sensory anchoring, recognizing that strict cognitive behavioral strategies could risk emotional detachment. Narrative therapy was introduced to allow Maria space to explore her story's meaning. Initial goals. At the beginning of the treatment plan focused on short-term realistic outcomes designed to alleviate symptoms, establish emotional safety, and regain internal control. The first target was a reduction of the frequency and intensity of Maria's intrusive memories, especially about the loss of her mother, as well as recent field traumatic scene reminders. A second short-term goal was the re-establishment of a basic support system, especially since Maria's grief had intensified her withdrawal from close colleagues and family. Third, Maria aimed to begin reconnecting with her spiritual identity, but not through immediate religious re-engagement. Instead, she was curious about what her religion had previously been for her and how it might remain significant within a new context of non-judgment. Finally, a broad initial aim was to normalize her emotional process and inform her that avoidance, guilt, and numbness constituted not a sign of weakness on her part, but were a manifestation of a trauma-affected nervous system and grief reaction. Additional goals as therapy progressed. As the treatment went on, several deepened layered goals came together, calling for a shift from relieving symptoms to reconstructioning meaning. First, the systematic introduction of the work of forgiveness, not the religious, but the psychological meaning of releasing the weight of unresolved guilt and injury, was one of the most significant shifts that ensued. 2. The second intention was embarking on collective bereavement and readjustment to society. Maria had initially viewed grieving as a personal issue. In therapy, however, she realized that she wished to reconnect with her ethnic and spiritual communities on unorthodox terms. A final integrated goal was for vocational reorientation. Maria began to question whether it was possible to work on the front lines of emergency service. Although she had always envisioned herself as a guardian, through therapy, she could imagine herself doing a different kind of service, a peer support mentor or a bereavement educator for Latina first responders. Conclusions. What worked? Several interventions worked with Maria, partly by infusing principles of trauma-informed care within culturally sensitive and spiritually responsive approaches. These interventions were effective because they respected the collectivist values and religious symbolism that were a part of her identity within the framework that dominant Western models of bereavement did not legitimize. First, trauma-focused cognitive behavioral therapy assisted her with learning some skills for managing flashbacks, emotional flooding, and avoidance behavior. A second accomplishment was bringing together symbolic ritual and storytelling, creating a home shrine and participating in rituals for the Day of the Dead permitted Maria to externalize her grieving and reconnect with her cultural bereavement rituals. Working on relational attunement, culture-sensitive language, and awareness of systemic and spiritual wounds constructed a firm partnership. What did not work as well as expected? Despite significant gains, part of the treatment process were not as anticipated and had to be adapted. In the first place, it was anticipated that Maria would easily engage with the work of trauma stories after stabilizing measures were put in place. However, her guilt over spirituality, internalized together with the fear of family shame, prevented her from being able to discuss hurtful memories, especially the disappearance of her mom. In addition, while Maria sensed a desire to return to Catholicism, there was resistance at the emotional level to organized spiritual rituals as well. There were some instances, however, where the therapy did not go too well for her. Maria initially perceived Western psychological concepts as unhelpful and dull. Phrases such as disordered grief or emotional dysregulation did not make sense to her unless explained within her own culture, such as being the circumcider, out of rhythm, which better reflected her issues within her language. Closing summary. Maria's case is a moving example of the convergence of trauma, loss, and spirituality, even across different cultures. It highlighted the need to address not only clinical manifestations, but also fragmented stories resulting from ambiguous loss, disrupted ritualistic grieving, as well as moral damage. Her case is a poignant reminder to practitioners that far too often it is not a single event that is traumatic. However, instead, it resonates across family boundaries, cognitive structures, and social networks. Regarding prognosis, Maria demonstrates strong internal resources, resilience, reflective capacity, and cultural pride. While her trauma history will likely require continued attention, especially around unresolved early loss, she has shown motivation and capacity for growth. With continued support that respects her unique spiritual and cultural identity, Maria is likely to experience sustained healing, deepened self-compassion, and renewed purpose as both a professional and a grieving daughter reclaiming her story.